The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
Now, the other thing that we're going to do here is talk a little bit about glycemic crisis management. And one of the things that we've identified as a faculty here is that we don't talk a lot about DKA, hyperosmolar coma, management of patients while hospitalized, and we recognize that there's a gap in our material there, but how much can you do, in 4 hours or 4 or 5 hours, and so we tried to cover more nuts and bolts things. However, we do have some questions here that we're going to throw at you. 16-year-old male has a 1-week history of polyuria, polydipsia, and polyphagia. On lab evaluation, he's found to have a serum glucose of 270, a bicarbonate of 9, a serum pH of 7, and a serum potassium level of 4. Which one of the most following accurately describes this patient's total body potassium? So look at the answers there. I'm going to give you a chance to think about it, and then we'll talk about it. So clearly he has DKA. He's got a pH of 7. His bicarbonate's 9. So if you have a bicarbonate less than 15 with a blood sugar above 250, that's considered diagnostic. pH is usually less than 7.2 in people diagnosed with DKA. So he meets anybody's definition of DKA. In which one of the following most accurately describes this patient's total body potassium? Well, you know that when somebody's acidotic, that your red blood cells buffer hydrogen ions, right? When they buffer them, so you shuttle potassium outside of the red blood cell, which actually elevates your blood when you measure serum, what that potassium level is. So if somebody's got a pH of 7 and they got a bicarbonate, or they've got a potassium level of 4, they're low, right? So as soon as you start treating this individual, their potassium is going to go down substantially because their pH is going to start going up. So answer your possible options here: mild potassium excess, normal potassium stores, C or D, mild total body potassium deficiency, or D, severe total body potassium deficiency. I think I don't know, I wouldn't split hairs over C or D. I think the important thing is to know this person's low. Very low, I would say, and probably D is probably a better answer than C, but either one I think's okay. All right, another question. We're almost through. Another one or two questions. 58-year-old obese male comes to your office with a 2-week history of fatigue associated with polyuria, polydipsia, and weight loss. You think he has type 2 diabetes. This diagnosis would be corroborated by a random glucose level greater than or equal to 200. Okay, so you guys have learned all the diagnostic criteria for diabetes. Fasting's above 125, A1C's greater than or equal to 6.5, 2-hour postprandials greater than 200. I don't think we talked about that, but a 2-hour postprandial greater than 200, or a random glucose with symptoms of 200 or more, okay? This one I kind of like because there's a lot of physiology in this one. Same kind of story here, like we saw before. 16-year-old female admitted to the hospital with a 1-week history of polyuria, polydipsia, and polyphagia. Examination reveals a lethargic, volume-depleted female with the smell of acetone on her breath. Her blood pressure is 96/70, pulse is 120, and she has Kussmaul respirations at a rate of 32 per minute. You guys know what Kussmaul respirations are, right? It's like And then pulse ox will be 100%. And you're like, why in the world are you breathing like that? That's Kussmaul respirations. Okay, glucose 525, sodium's 122, potassium's 3.1, chloride 95, CO2 7, pH 7.1, PCO2's low, PO2's normal. So clearly has DKA. So here's the question. And this person really, fairly severe TKA. But after initiation of IV fluid therapy, which one of the following should be done next? All right, you ready? Get your blue boxes out. Well, good. You guys did better than I expected you to. This one is kind of tricky because you're always taught that, you give somebody who's hypotensive, give them saline, wrap it up. Okay. And but this one, the patient's so low on potassium, a potassium of 3.1 and a metabolic acidosis, that as soon as you give this patient insulin, you're going to crank that sodium potassium pump up, and the potassium is going to plummet even more. And so this is the one case in which you might give saline and then give a potassium cocktail and then start insulin. Okay, that's the take-home message there.